where we'll be talking about post-traumatic stress disorder and personality disorder. Next slide. So the objectives for this session is understand trauma and its biological effects, differentiate between personality disorders, and acquire and utilize skills with which to interact with community members who have experienced trauma or have a personality disorder. Next slide. Next slide. So I wanted to start this talk with everybody thinking about stress. And so I wanted to do a Menti poll. So hopefully everybody will participate in just describing what types of stress do you usually experience. Work, yes. Deadlines, school, yes, expectations. Your research, career, and just future, what's going to happen next. Yes, there's a lot of stress out there. Feeling inadequate, health. Yeah, maybe failure, feeling like a failure. Perfectionism can be stressful. Okay, we'll give it a few more seconds. Okay, well, yes, there's a lot of stress, and I think everybody understands stress because they've dealt with it themselves. Let's go on to the next slide. Okay, so since you all have stress, how do you typically deal with stress? Ranting, okay. Crying, you don't know. Taking a nap. Eating, exercise, meditation, wonderful. Running, exercise, a lot of people exercising, running, dancing, I like that one. Uh-oh, there's a dysfunctional state. I'm not sure what that means. Drugs. Okay. Alcohol. Talking to a friend. Yeah, focusing on what you can control. Okay. Yoga, prayer. Self-care. Yes, that's a big word these days. Music, reading, watching Netflix. I can understand that one. Okay, well, with a lot of stress, a lot of ways that people are managing their stress. That's good to see. Okay, well, let us start talking about stress. So stress, what is stress? Now, you all have talked about it, so you sort of know what it is, but it's really a vague term these days. Back in the sort of ancient times, hunter-gatherer times, when there was wild animals out there, stress was related to acute physical danger. So a wild animal's coming at you, your stress response system kicks in, and you have, stress response system kicks in, you got your fight or flight. So you either run away or you try to fight for food, and your stress response system sort of takes you back to what we call homeostasis, or just this sort of internal equilibrium, so sort of the non-stress state. But these days, stress is more acute or chronic emotional stress. And that can be almost anything, which you all have sort of displayed. But everybody knows stress because you don't feel good, you feel off kilter, you don't feel like yourself. You could be either frustrated because you're fighting with a partner. You could be either overwhelmed because you have a job and kids. You could be exhausted because you have 2 or 3 jobs. So it could mean almost anything, but it's the same system that was used back when you had wild animals going after you, the stress response system that's at work trying to help you deal with these stress. And so we'll talk about whether the stress response system has been able to sort of keep up with the modern day stressors. Next slide. So there's just degrees of stress. We see healthy stress, tolerable stress, and toxic stress. This is not necessarily talking about the types of stress that you have, but it's referring to how the stress response system has been able to sort of keep up with managing the stress for us. Has it been able to manage it, or has it broken down and in the long run maybe done more harm than good? And so we will talk about that and get more into these types of stressors. Next slide. So the first thing is a positive stress, or what we call healthy stress, or the stress that we all know and maybe love. It's that kind of stress where, you know, when we talked about the wild animal coming at you, you have the stress response system, you're able to fight or flight, and then things go back to normal. This is when there's a brief stressor. It gives you motivation. So your test is coming up, and 3 weeks from the test, you're not that concerned about it, but 1 week from the test, stress response system starts to kick in. It gives you that motivation you need to study and hopefully do well on the test. Maybe if you're going to work and your alarm doesn't go off, and then you realize that you've gotten up late, the stress response system can kick in and give you that extra motivation in order to possibly still get to work on time. So this is the system where, or these are the stresses that the system was designed to help us with. It provides us and enables us to be able to function. And so therefore it has been what we call positive or healthy for us. Next slide. Then we have what we're calling tolerable stress. This might be a more severe type of stress, but it's still time limited. And your stress response system is able to help you with it, but you still need to sort of step in and do some other things. And you all have talked a lot about those other things, like interacting with supportive family, healthy practices like exercise and meditation. But the stress response system with these interventions also allow your system to go back to homeostasis or equilibrium. So you can think of an example like divorce, where you're separating from somebody, you're dealing with lawyers, and the divorce may take, let's call it 6 months. During that time period, hopefully you're engaging in some of these healing practices, and they're actually helpful. So you are stressed because you just had a meeting with somebody about the divorce, but then you go running. And so your system has an opportunity to regain homeostasis. Or you talking on the phone with people and you know that you have a hearing coming up, but you're still able to intervene over this 6-month period to help yourself get through once the divorce is finalized. then your system goes back again to the homeostasis or the non-stressed state. Next slide. But then we have toxic stress. And toxic stress is when the stress is more significant, possibly it's more intense. It happens multiple times. It can be prolonged or chronic. And the difference here is that you're not able to manage it. You're sort of utilizing all of the healing practices that you had tried before. You go to family members, but for whatever reason, you're still feeling stressed. You try to go running, and that doesn't seem to work. And so your body seems to stay a little bit higher in this hyper stressed state. So your body does not go back to what we've been talking about, homeostasis or the non-stress state. So that can be, again, if we go back to the example of divorce, you might have custody battles that happen over time. Just when you think the divorce is final, it's 6 months, then 2 or 3 months later, you're going back to court because of custody issues. Then a few months later, when you think that has maybe died down, you notice that your money is getting low, so you have to pick up a second job. And so you're stressed about that. You've got kids, and just sort of the stress kind of keeps going on. And as I mentioned, the healing practices are inaccessible, they're insufficient, they're unsuccessful, and therefore your system does not go back to homeostasis. It goes back to what we're calling a new normal. So you're just a little bit on edge all the time. Maybe you're not sleeping well because you're on edge. Maybe your blood pressure goes up a little bit. Maybe you start to become more irritable, start snapping at the kids. Now that you're having some symptoms, maybe then now you're going to start to go and to see the doctor to try to deal with some of these issues. And so since your stress response system does not return to normal, then you're starting to have physical symptoms, maybe emotional symptoms. You might start to have anxiety or depression. And so toxic stress starts to move you towards having long-term physical and mental health issues. Next slide. So I want to try to do another Menti poll. We'll see if it works for this. But so now that we've talked about healthy stress, tolerable stress, and then toxic stress, what is trauma or traumatic experiences? Child abuse, yes. When you're feeling you are going to die, yeah. Family member dying. Situation that leaves a lasting impact on someone's mental state, yeah. Long-lasting effects post-event, yes. Prolonged traumatic experience. And experience when you experience toxic stress.
I apologize, Dr. Brown. I'm trying to make these scroll, but they don't seem to
Okay, because I
want
was
to.
trying to see if
Oh, here we go. Here we go.
Okay, here we go. It sticks with you, yeah. War, your side effects after severe burnout, hospitalization, situation that gives a person an intense emotional reaction, yes. The victim perceives it, yeah. Okay. Psychological damage that alters your ability to respond to future stress. Okay. Verbal abuse, physical abuse. Okay, well, these are all good things. So let us try to talk about the stress response system, a little bit about the biology, and then we can start to better understand trauma. So I know that you had talked about the stress response system in the past. So I'm just going to go over just some basics about the system, and then we can talk about how the stress response system, when it's dysfunctional, can lead to disease. So as you've heard in the past, the stressor comes in through the brain and the amygdala, and then the amygdala signals the hypothalamus, and the hypothalamus will signal the adrenal gland to secrete adrenaline, and that adrenaline is in the sympathetic part of the nervous system, and that's the hyperarousal side, where you have your increased heart rate, increased blood pressure, increased respiratory rate, and increased muscle tension. Of course, we know that as a fight or flight that gets you ready to deal with whatever comes your way. Then the hypothalamus via the pituitary gland hits the adrenal gland again and releases cortisol. Cortisol can also be instrumental in maintaining blood pressure. It also mobilizes chemicals for energy like glucose, but it also, as the stressor is diminishing, can bring in the parasympathetic nervous system, which is the sort of hypoarousal system, starts to bring things back down to homeostasis. That is sort of the simplified version of really what is going on in general stress responses. Next slide. And so how does that lead to diseases, including a post-traumatic stress disorder? So if we're looking at the sympathetic side of the pathway where adrenaline is released, as we talked about, the adrenaline can increase your heart rate, you can increase your blood pressure. And as we talked about with toxic stress, if these systems don't go back down to normal, then if your blood pressure is high, then it's sort of at a new normal, and you can start to develop hypertension. Because of the blood pressure being high and the heart rate, you can start to damage your blood vessels and lead to coronary artery disease, have a heart attack or a stroke. Moving on to cortisol. Cortisol also helps in maintaining blood pressure, so it can be instrumental in hypertension as well. We also talked about cortisol and its ability to mobilize chemicals to utilize them for energy. And one of those can be glucose. With high glucose, cortisol can also lead to insulin resistance, and therefore that can lead to diabetes. Cortisol also influences or interacts with it can also impact your memory. And so therefore this can lead to diseases like Alzheimer's disease. And then when we get to the parasympathetic nervous system, that is where if you have a stressor, and we've talked about, it's not necessarily about the stress, it's about the system itself. But if you have a stressor, if you've dealt with toxic stress and the system is starting to break down and you're leading to higher and higher levels of these chemicals, if you have a stressor that kind of pushes you over the edge, then the sympathetic nervous system and the parasympathetic nervous system are sort of on autopilot. They're sort of stuck on high. So you have the sympathetic side where you have the hyperarousal and you have all the things that we talked about with that, but you also have the parasympathetic side, which I said is the opposite. And that can give you symptoms that are more in line with post-traumatic stress disorder, and we'll get to those specifics. But that's when you start to see people that are sort of in this dazed and kind of confused state. They seem to be detached. They don't know what's going on. You might talk to them and they don't seem to know what's happening. They may not even know who they are. And we call this kind of dissociative state. And so in terms of post-traumatic stress disorder, it's not about what the stressor is, but it's about how the system has managed stress up until that point. And is this a breaking point for a given individual that might send them down the path of trauma And like I say, we'll talk about the specific criteria and how one would meet that diagnosis. But people believe it's the sympathetic and parasympathetic nervous system that's involved in that. The next issue can be oxidative stress. When we are utilizing a lot of chemicals for energy, oxygen is involved. And if oxygen is involved, a lot of their byproducts can be harmful to cells, and harmful to cells such like free radicals. And because you're under a lot of stress, there's a lot of harmful chemicals running around that the body really cannot mop up. If the stresses are normal, then we have systems internally that could manage those stressors. But if it gets out of hand, then you have free radicals and other chemicals that can do damage to cells, and that can lead to things like dementia, cardiovascular disease. I think you also talked in the past, I'm not sure exactly when, about telomeres, but that's the end of chromosomes. And normally those telomeres shorten by, let's say, 50 base pairs every year based on just the aging process. Under stressful situations, that can go up to over 500 base pairs. And a lot of people have seen some associations between oxidative stress and that process. And lastly, I just put in this about epigenetics, but that's sort of the process where the environment interacts with genes. And so it allows for whatever you're dealing with environmentally to turn on and off genes, and whether the genes are on or off, that dictates how the cells function, which of course dictates how you function. And so that's the sort of pathway where you can see how stress might impact the stress response system. And over time, depending on what genes are turned on and off, that system may start to break down. And that's how you might move into diseases, as we've discussed.
Dr. Brunner, it looks like in chat we have a question.
Okay.
Corbin asked, is it recommended for people who suffer from oxidative stress to have a diet high in antioxidants?
Well, it can certainly be helpful. It's unclear, how helpful it will be in terms of the level of stress one is dealing with. I don't know, if anybody has done research on that, but, one would think that that could be helpful. Unclear how helpful based on, how the intensity of the stress, how long it's been going on, and how much damage has been done. Is there another question? No?
Yes, I have a question.
Yes.
So you talked about the side effects of stress. So what if like someone who gets stressed out easily and decided to take it on people around him, is that person gonna still experience the side effect of stress or no?
I actually couldn't hear that middle part of the question. Can you repeat?
Yeah, of course. Can you hear me now?
Yeah, you're more clear now.
So I said you talked about the side effect of stress.
Yes.
And what if like someone gets stressed out easily and decided to take the stress out on people around him? So is that person gonna experience the side effects of stress or no?
So taking out on people around him, meaning what, getting angry with other people?
Like getting easily angry, easily irritated, yelling, shouting. Is that person gonna experience the side effect of stress?
Yeah, because those are the sort of hallmarks of somebody that's overstressed or dealing with toxic stress. That high level of hyperarousal puts people on edge, and that's why they're probably engaging in those kinds of activities. So they're probably way down the road in dealing with stress or not dealing well with stress, and so they're probably in the toxic level. And so all of these processes that I've talked about are probably already underway. I mean, the issue with these processes is that you're dealing with the stress today, but you may not see the manifestations of that until, 5-10 years down the road. So hopefully that answers your question.
Thank you.
So moving on to, and this just is a slide of, the different types of stressors. As we said, it could be anything, because really how you're dealing with stress is more about who you are and how you perceive a stressor or what's happened to you in the past. And so I know that you've all have talked about social determinants of health in past lectures. And so we know that the environment that people grow up in can be very stressful. If you live in a particular community and there's a lot of violence, and you might be dealing with stress on a daily basis. You may be hearing gunshots at night. And so every time you walk out your door, you're stressed because you don't know if you're going to be next, or that somebody has recently died in front of your house. I mean, these kinds of stressors can be intense and they can build up, or they can be low level but still chronic and create the same problems. We talked about racial issues, racial injustice, there's sexual orientation, there's gender, all these marginalized groups who on a daily basis or on a weekly basis are assaulted emotionally and maybe even physically. And so we can start to see how a lot of these stressors through the biology can start to pile up and build up. And as I said earlier, and based on the question that came through, that we're not going to necessarily see the bad effects until down the road. And so a lot of times people don't connect what the stressor is with some of these outcomes. But I think one of the biggest issues that we're facing today really is this issue of abuse and neglect in children. Because if you can imagine, at least if you get to an adult's age or at least older than 5, your brain has developed in, hopefully in an appropriate way. Your stress response system has developed in an appropriate way. And at least you have an initial chance of dealing with all of these kinds of stressors. But if you have stress or trauma when you're young, when your brain is just starting to grow and develop, you can imagine that the stress response system probably will not develop in the right way. And so you have a lot of kids nowadays who are in this chronic state of trauma, and they can be restless in class. They can be on edge like anybody else. So they can have a lot of conduct issues. They can be the sort of person that has to go to detentions and those kinds of things. They also can be have problems with attention, and they can also be the opposite in terms of, we talk about dissociation. They can be the child that's sort of sitting and staring out the window, and if somebody calls on you, they have no clue what's been going on. A lot of times we can make diagnoses of these people. Sometimes they get diagnosed with ADHD or some kind of mood disorder. We start to treat those things, but we don't actually know where they're, or don't really, well, you don't know where they're coming from. So you're treating really the symptom and not necessarily the problem. So if you are treating somebody with ADHD and really the issue is abuse and neglect at home, then you're not really actually solving the problem. And the bigger issue is not only does the child have an issue, but when they grow up and you haven't dealt with it, then they have a child, and then this whole cycle continues to churn. And so, where are we with this toxic stress and trauma? Where can we intervene and try to help and prevent this from happening? And it's hard to know these days because there's so much distress out there. And the last one is isolation, and basically the pandemic and COVID. And so this past year, people have really started to see how significant isolation is. I mean, we didn't have just the pandemic and all of the shock of this virus that nobody knew. People were dying. We didn't have a treatment. I mean, that can be stressful enough. And then they said that the treatment for this for us for now is isolation, staying away from people. And so I think people did not realize how important it was to have connections with people. And we could see some people sort of say to themselves, I can't do this anymore. It's too much, it's too stressful. And so, I work on an inpatient psych unit, and we started seeing people coming in, particularly older people that were more isolated, and, they had exacerbations of underlying mental illnesses like depression and anxiety and, any other mental illness that they may have. And so this pandemic and social isolation has really been a problem. And really, it's something that people have to recognize down the road. If somebody comes in traumatized, maybe this time period started them down the process of toxic stress, and whatever happened in the future may have pushed them over the edge into trauma. Is there a question? Chris? Oh. Okay, so next, oh, there's a question.
I see that someone said that they have a question, but they
Okay.
didn't write it in chat.
Yeah, I have a question.
I can't hear you.
Can you hear me?
A little bit. Try it again.
Can you hear me now?
I can hear you. I can't hear you now.
So my question. So how can you get over a toxic stress if someone grew up in a toxic environment?
And we'll talk about treatments for this. And so hopefully you can hold your question till I get the treatments. And then if you still have it, then we can talk a little bit more about it.
There was also another question that asks, can toxic stress or trauma be caused by chronic pain?
Probably. I mean, pain is stressful. And, possibly the reasons why somebody has pain could be a reason that's stressful as well. Or somebody could have chronic pain because they had been stressed in the past. So they may already be going down the road of toxic stress. And this is maybe a manifestation of that, because a lot of times when people are overstressed, their muscles get tight and then they can have pain. Or if they already have pain, toxic stress can make pain worse. And so, yeah, pain is very instrumental. It can be in this process. Okay, let's go on to the next slide. So let's talk about what it takes to get to a diagnosis of post-traumatic stress disorder, because one of the things to be clear about is, depending on what type of event somebody has and what type of symptoms they have, they may or may not have what we are sort of calling post-traumatic stress disorder. We have the DSM, which provides us with the diagnostic criteria. And so somebody would have to go to a mental health professional in order to have that diagnosis made. But the first criteria in the DSM-5 for PTSD is that they're exposed to actual or threatened death and serious injury or sexual violence. So this basically sets up the scene to say you've had a traumatic event. That's either directly experienced, witnessed, you learn from somebody that a close family member was involved in a traumatic event or lost their life, or you experience repeated extreme exposure to adverse details of a traumatic event. That may be some like a first responder that has to deal with some kind of tragedy or trauma that they have to sort of keep reliving in order to do their job. Could be an example of that. Next slide. And so criteria B, you have to have one of these criteria, and this is basically re-experiencing the event things that kind of keep the stress going because you're either thinking a lot about it, you have dreams about it. Dissociative reactions could be flashbacks, so during the day you sort of are recreating some of those symptoms or some of those scenes that happened during the traumatic event. And so you have to just have one of these criteria in order to possibly have a diagnosis of post-traumatic stress disorder. Next slide. Criteria C is about avoidance. And so if you recognize that you had a car accident and you don't actually want to go towards another car or drive another car, so you tend to maybe ask other people to take you around. So basically trying to avoid any of those memories, thoughts, or feelings that might trigger some of these anxiety symptoms, and avoidance of people, places, and situations that might do that. And some of the consequences of this is, you know, the more and more things you become avoidant of, the more isolated you can be, and you're just basically reinforcing the fact that this particular thought or feeling or place might cause anxiety. But you have to have one of these towards a diagnosis of PTSD. Next slide. Negative alterations in cognitions and mood. And so you have to have two of these in order to move on to post-traumatic stress disorder. Some of these symptoms are related to the ways you think about things. Some people blame themselves. Some people lose trust in other people, depending on what kind of stress that they had. You can have a lot of negative emotions related to this, like anger and sadness. You become detached from people and more isolated. And so, like I said, two of these symptoms would move you towards a diagnosis. And then next slide. Last one is about hyperarousal. And again, if you're on the hyperarousal side, you can be irritable and angry, reckless, you get hypervigilant, you have sleep problems. And so you have to have two of these symptoms in order to meet the diagnosis of post-traumatic stress disorder. So this is how we would be trying to make a diagnosis, you know, based on our interview with patients and talking to them about what's happened to them and trying to better understand their symptoms. We can try to make a determination of whether a person has a diagnosis of post-traumatic stress disorder or not. Next slide. Okay, so let us get into the treatments. So the most studied and most effective treatments are psychotherapy. And so the first type of psychotherapy, and we call these trauma-based treatments, is prolonged exposure. And it is basically what it is saying. It's a person is exposed to the trauma-related memories, feelings, and situations based on them talking about them, based on them writing about them. And the idea is the more you're exposed to it in a situation where nothing bad happens to you, then you start to learn that these triggers are not dangerous, and then hopefully you will stop avoiding those things. And so as you can see here, there's weekly sessions, about 90 minutes, and individual, and then you have homework where a lot of times you might in session sort of talk about things. You might have physical sensations that you're dealing with or memories, but then when you go out into the community, they might say, you know, if there was an explosion at a gas station, I want you to, you know, slowly, and this is gradual process, you're not going to sort of jump into anything that's too stressful, but they may want you to at some point go back to a gas station and then maybe go back to the gas station. And they also teach you stress reduction techniques to help you manage the stress. And the more you go, hopefully, the more those stresses will diminish. Next slide. The next treatment is cognitive processing therapy. And this is where you might have distorted thoughts or maladaptive thinking about what has happened to you. And what they'll tell you is, you know, your thoughts lead to emotions, and your emotions and thoughts can also lead to maladaptive behavior. So if you start to challenge that thinking, then you can start to change the way that you feel and the ways that you behave. So if somebody says that I don't trust anyone after somebody maybe violated them physically, and then they say to themselves, I can't trust anybody, I got to stay in my house, I can't go anywhere, people are going to start to, you know, they might feel like other people might try to harm them. What you might do is try to challenge them on those thinking. Well, you know, there's one person that hurt you, but you also said that you had a couple of friends that you can trust. Oh yeah, I did say that. And so maybe you can start to have them sort of really start to think, well, maybe it's not everybody I can't trust. And at some point they get back to the fact that, well, there was that one person that violated me, but I still have other people in my life that I can turn to. And therefore, hopefully that thought will start to fade away, and they can start to really gain some of the support that they need to get from their connections with other people. Now, this can be individual or group. And so in this kind of treatment, you don't necessarily have to fully talk about the trauma per se, but you can just deal with some of the sort of fallout, which would be some of the negative thinking and maybe negative behaviors that you're experiencing. And so for some people, this may be a better type of therapy if they feel uncomfortable sort of reliving their stressor or trauma. Next slide. Okay, so the last psychotherapy is called eye movement desensitization and reprocessing. And this type of treatment has you focus on specific memories, not necessarily the whole trauma itself. And what this treatment says is that when you have the trauma, it was not processed in your brain correctly, which is leading you to these negative symptoms. And so what it says is that if you're thinking about the memory and they have this sort of what they're calling bilateral stimulation, which a lot of times is eye movements where your eyes move back and forth while you're thinking about it, they believe that this can cause your brain to process the treatment in an effective way and therefore decreased your level of symptom. The jury's still out about exactly how this does that. But there's some people that believe, even though you're not thinking about the whole trauma, that you do talk about or think about specific memories, and this may be some kind of form of exposure therapy. And so, you know, still a lot of research out there on this treatment, but there's a lot of research that says that it is helpful, even though they don't know specifically how it may help. But the issue with therapy in general is, you know, access to treatment and, you know, retention or staying in treatment once you get there. And so, you know, we talked, you may have talked about all these issues about access that have to do with insurance, that have to do with, you know, where you're living. Maybe you're so far away that you can't get to treatment. There may be cultural issues where you don't feel like there are enough people that look like you, so you don't maybe trust things. And so, you know, what they're saying about these treatments that work is if you actually get to treatment and you stay in treatment, then it can be helpful. But obviously, if you can't get there, you don't stay long enough, then these things can't be helpful. So there's a lot of research on trying to obviously improve access to treatment. Next slide. And then we have some medications that we use, but the big picture about medications is that they're are a lot of studies out there about specific medications. Some studies are positive on a particular medication, and then you find an equal number of negative research on that particular agent. And so most agents aren't well studied, and so we don't have a lot of research to back up a lot of the things that we do in clinic. But we do, antidepressants are the most studied, and actually they do have some FDA approval for 2 antidepressants, one called Paxil or paroxetine, and the other one called Zoloft or sertraline. And so those are FDA approved. However, we do use a lot of medications off label because we just don't have the research out there to show that these medications are helpful. So we have a lot of antidepressants that we use that can be effective for some and may not be effective for others, but we can try those 2 that were FDA approved, but we try other medications as well. And a lot of those decisions have to do with how people may have responded in the past, side effect profile, those types of things. And so, unfortunately, we don't have a lot of guidance in that area. Next antipsychotics are another type of medication that we use to treat patients with post-traumatic stress disorder. Antipsychotics have been looked at in terms of some of those re-experiencing kind of symptoms and the sort of pseudo paranoia where some people feel like, I've been violated once, I might be violated in the future. There's been, a little bit of a signal where those medications may be helpful, but we tend to use antipsychotics to treat people that have agitation or aggressive tendencies, people that may be more anxious or have sleep problems. A lot of antipsychotics we use, one medication called Seroquel. That medication, if you use it at low doses for some people, that can be helpful for sleep. If you use it at a little bit higher doses, that medication can be helpful for anxiety. And it can be helpful for people with agitation. And so some of the antipsychotics are pretty versatile in that way. Adrenergic receptor agents, those are medications that really act on the sympathetic side of the pathway, so the hyperarousal. These are medications that try to counter that hyperarousal, and they actually have been used in treating people with nightmares. I've actually had a lot of, one of the medications is clonidine, another medication is prazosin, and I've used that a lot with patients and really have been very successful in helping them with nightmares. And so some of these medications can be very helpful, at least in treating some of the symptoms. And then we use medications to help people sleep, because if you're sleeping well, you tend to do better just in general. If you're not sleeping well, whatever's going on is actually just is worse off. And so I spend a lot of times talking to patients about sleep, and there are behavioral ways that you can manage it, but there are also medications that we can use. And as I mentioned, antipsychotics can be helpful. There's various antidepressants at low doses that can be helpful for sleep. So we have, an arsenal of medications mainly to treat some of the consequences of the disease, but not necessarily treating post-traumatic stress disorder in general. Next slide. So I'm going to do another Menti poll. So what would you do if you thought somebody had experienced a traumatic event? If this may be good for a Menti poll, I'm not sure. Make sure they were able to process it, refer them to a clinician. Okay. Ask questions. Communicate with them in a way that reflects their boundaries. Okay. Right. Ask them if they needed help, listen to their story, allow them to vent, talk, check with them on how they're doing. Yeah. Be kind. Yeah, I like that. Check in, but be cautious not to trigger them. Yeah. And make sure they know that you're available, that you don't want to necessarily intrude, but they at least know that they have somebody to turn to. Refer to appropriate resources, yeah. Listen, active listening, yeah. Okay, well, let me move on because actually time is getting away from me. So back up one. Yeah, so the most important thing is listening. I mean, that is the most important tool that we have in our toolbox, not necessarily just in the community, but actually for clinicians, people in the hospital. You want to listen to what their story is, because as we've been saying all along, you don't know what's going on. You don't know whether they have been traumatized, they may not have been traumatized, you don't know their history, you don't know what's happening. And I think when people are stressed, everybody wants to sort of jump in and try to do something, try to fix it, try to solve it. And really, you need to listen to find out maybe what it is that they need. Yes, they may want to vent, they may want to just tell their story. But in telling their story, you may get a hint of maybe what they might need. And so you can be more successful in helping them if you know what's going on. Next slide. This is what I call back to basics, because this is what I do a lot with patients. One of the reasons is that when we start people on medications, it can take a while for some of these medications to kick in, sometimes 3 to 6 weeks, 2 to 3 months that it might take. And so I'm working with them on sleep. You know, I talked about behavioral ways that you could do that, and something called sleep hygiene is something that we talk about, and you can actually go online and look at how one might do that, but it's basically trying to implement things that are helpful for sleep and take away things that are not helpful for sleep. And a lot of times I give people handouts so they can take those things home and they can go back and look at them and try to implement those things. Are people eating 3 meals a day? I mean, that's, you know, sort of low level and basic, but I mean, if they're not, then they're not going to be doing well. And not just eating meals, but could they be healthy meals? Are they drinking plenty of water so they're not dehydrated? Are they exercising? Are they engaged in any stress reduction types of things like exercise or meditation? And so those are the things that you can be talking to people about, and making sure that they're engaged in these activities as a baseline. And then, you know, they may need to have other things happen, but, you know, things usually aren't going to go well until these things are in place. And a lot of times I tell people to do this as a routine. You don't want to wait till the stressor starts to happen before you start to implement some things, particularly stress reduction types of things. And so you can help them maybe figure out what those things are. You can maybe walk with them and maybe be a part of their exercise activities or something along those lines. Next slide. Mindfulness. And so I wanted to just talk about mindfulness as a way to decrease people's stress, and maybe just engage people in a minute or so in a mindfulness exercise. And really this mindfulness is just present moment awareness of things that are going on around you. Most important part of that is without judgment. And so, and also you may have to recognize that your mind is going to wander. And so that is also a part of the exercise. But what you don't want to get into is sort of saying my mind wandered too much and therefore I can't do it. Or, you know, you looked outside and you saw a gray sky and you start thinking, why is the sky gray? I can't believe it's still raining outside. Why did I move here? And all these negative things. What you want to do is recognize when your mind goes to these things and sort of gently and kindly bring your mind back to what you're focused on. And so just in the next few seconds, let's try to use our sight. And so what you can talk to people about is saying, what is it that you see? And you just start to notice what is in your field of vision. You know, if you're near a window, you may start to notice maybe there's cars in the parking lot. You might see a green car, you might see a red car. And so you just ask people to start to think or to start to look and start to notice what's in their environment. And so maybe you can take a few minutes and use your sense of sight to focus on what's in your environment. If your mind starts to wander, bring it back and focus on what's in your sight. And then one can move on to other senses like smell, if there's smells in the area, or hearing. A lot of times people do mindful walking. And so when you're out walking, you're noticing your feet hitting the floor, you're noticing maybe the wind blowing on your skin, you're noticing things that are that you're noticing, like trees and those kinds of things. So it kind of keeps your mind in the present moment. And again, as your mind starts to maybe wander towards the stressor or towards the past or worrying about the future, it's just a matter of noticing those things and moving your mind back. And again, there's a lot online about this. You can print things out, give it to people, practice with them. And one thing you may want to try to do is do it on your own first, so you better understand it and better know some of the pitfalls, so that then you may be more helpful to somebody else. Next slide. And so the last thing, of course, is social interactions, and we've talked about that as well. So next slide. So this is the end of my section. We can take a break, I think, for 5 minutes, or if there's any other questions, this is a good time to ask those questions.
And I guess before the questions come up, but I'll get started again at 8:06. But anyone that wants to hang around and ask questions in the interim, feel free.
I see there are 2 questions in the chat. Were those answered? Can one be diagnosed with PTSD in the event of something like emotional or verbal abuse? Could the effect of that abuse qualify as a type of serious injury?
Yeah, and a lot of time, this could be, if you have those kinds of injuries, there could be accumulation of over time, and then a particular event could push you over the edge. So yes, all of these things can be toxic in nature, and then at some point could push you over the edge into trauma.
Another question was, are clinicians starting to make a distinction between complex PTSD and PTSD, despite complex PTSD not being recognized in DSM-5? Is treatment different between the 2 disorders?
Well, I think people believe that it is the case, and I think a lot of more people are talking about it. And so, I think we're needing to move in that direction in terms of making that distinction, because a person that might have a traumatic event based on, a hurricane coming through as maybe their first event, somebody that has adverse childhood experiences that are chronic and over time, people do see those 2 people as different. But I think we still have some ways to go in bringing it into the DSM and then making more people aware of it.
Thank you. Those are all the questions in the chat.
Okay.
All right. I'm going to go ahead and get started. I met all of you at the second session about stress and emotional support. I'm Chris Ramsey. I'm an intern at Duke, and I'll be talking about personality disorders. Just a quick thing before I get going. If you have a question, feel free to speak up when I'm at a stopping point, or put it in chat. I can't read chat and scroll through these slides at the same time. So if Bruni or Dr. Brunner, if you want to just keep an eye on chat and let me know if there's a question, I can try and answer those as they come. All right, starting with a poll. What is personality? What is you all's understanding of what a personality is? Someone's way of moving through the world and interacting with others. Okay. Durable traits. How you treat others and treat yourself. Differences, how you express yourselves. Quirks that demonstrate how you view the world and people. Outward self. I would actually argue that it is both your outward self and your inward self. How other people perceive us, that's kind of in the same as the outward self. Traits and values, set of behaviors. All right, I don't want to run too far behind. I know a lot of the stuff in the rest of my presentation will take a little bit of time, but this is a good baseline to start from. Great answers, everybody. So the definition, ignore the second bullet point. This is pulled straight from Google. It's the combination of characteristics or qualities that form an individual's distinct character. So yeah, you guys were right on the mark. Something that distinguishes us from somebody else, our way of engaging with the world. Now, the sort of stereotype about psychiatry or psychology is that it's all about early life, and personality is sort of like that as well. If you know anything about child psychology or psychiatry, or you go into this field, you will hear a lot about this man. His name is Jean Piaget, and he created a theory for the 4 stages of development of a child's brain. And these are the 4 stages, going from youngest to oldest. A sensory motor stage, sort of at a very young toddler age, pre-operational, like young school age, concrete operational, like maybe 7 to adolescence, and then formal operational, sorry for that typo, which is sort of like in a teens to adult stage of development. Now, these are cognitive development, so they don't directly tie into personality, but it's important to keep this framework and sort of, this shows like basically what our brains are preoccupied with doing during the development stages, right? So obviously, when you're 0 to 2-year-old, you're working on sensory motor things. You're working on what your eyes are seeing, what you're hearing, how to make sense of that, how to grab things, how to do that. So you can't really focus too highly on sort of less concrete things like personality and how you feel about things. Now, pre-operational, you start to get some of that. You start to get some symbolic thinking, and you start to gain interest. But you're also, abstraction is a little bit difficult. And it's not until you get all the way to formal operational where your personality and some of these abstract concepts like morality become cemented. Now, the point of this lecture is not to sort of hammer home all these cognitive development stages, but just to sort of set that framework is that you're going from just basic interaction skills all the way through theoretical, hypothetical, and sort of more abstract thinking. So, important things. Attachment style. This is centered early on. It's basically how you relate to others, right? Relationships. Honestly, we would be nothing if we were solitary animals. Humans are social, and we rely on others to sort of form our identity. A social understanding, like I just said. If you don't understand others, you'll have a hard time identifying yourselves because you have no template to go off of. And the emotional competence that goes along with it. If you can't understand how others feel, you're going to have a hard time making it in society and finding who you are on top of that. And temperament. Temperament, which I think is on the next slide, but I can go right now into it. Temperament is sort of like, it's genetically coded. It's like basically the Play-Doh with which you can form your personality. It is how you're coded to be right off the bat. So, I mean, a lot of babies, you can see that there's cranky babies, there's smiley babies, there's giggly babies, all these different temperaments, you can see it, days old, like that's just how they're wired to be. And so that temperament serves as sort of a foundation for what the rest of your personality would be. Oh, I didn't have temperament on the next slide. All right, glad I talked about it. All right, So there are two attachment styles, secure and insecure. If you are a secure attachment style, you were likely to have gotten a lot of warm, supportive interaction with your primary adult sort of role model in your life. And as a result, you can trust that the world is sort of a very consistent and a very forgiving place, just because that's how you were raised. On the opposite side, if you were raised in an environment where it's not very warm, it's not very forgiving, your attachment style would be, in a sense, insecure, in that you can't necessarily trust that things are going to be consistent. You can't necessarily trust that people are going to be nice to you, because that's not what you've experienced up to this point. And in a sense, some of these social determinants of health are something that plays into this. It's not just adult role models, right? If you experience poverty as a young child, you can't trust that, food's going to come, and therefore your attachment to things and to other people is going to be affected. Relationships. All right, we got another poll here. What do you think is the most important relationship in child development? Parent. We've got some votes for peers and siblings. I'll give you all maybe another 30 seconds to get a few more responses in, and then we can talk about I think I coded it right so that we can see the correct answer on the slide, but otherwise I can just talk about it. All right, looks like everyone's in that's gonna be in. Nope. All right, well, oh, here we go. Yeah, so parent is the correct answer. It is a bit of a misleading question, because I didn't say what age of child. Your peers gain more and more significance as you get older, especially with teenage years. But regardless, throughout the entirety of childhood, parents are a very, very important sort of foundation for our development. But all three of these answer choices are valid. Siblings, peers, and parents are huge relationships that are very important. Other ones that are important, teachers, people that you come in close contact with, other family. But I have another quote from Mr. Piaget here. I don't know what context this was said in, but it does help illustrate the point that things that we experience from our parents, whether good or bad, sort of imprint onto us. And this was his example, but sometimes you'll see, oh man, that kid, he turned out just like his dad. Good or bad. You can see a guy, with a father who drank a lot and was not very nice or abusive, and there's like a cycle of violence, right? His son will turn around and do the same thing. The other side of it is, say Archie Manning, right, and his son Peyton Manning. Both really loved football. They both went to the NFL. It can go both ways. Now, part of why parenting is so important is that you are the primary figure in a psychological sense. You are the primary figure in your child's life, and from a psychological perspective, mother especially, is that mother is the very first person that a baby meets, right, in the world. So they are all that's good and all that is bad for a long time. Dad comes in pretty soon after, at least in traditional families, and then other people get involved later. So a parenting style plays a huge role in how someone is formed. Now, I have a chart here, and the types of parenting is not a big takeaway from this lecture. But I will say, let's see if I can write on it. Here we go. Authoritative parenting has been the subject of a decent amount of research recently, in that it is a nice blend of high warmth and sort of forgiveness, but also expecting a lot from your child, and that helps sort of get positive stress towards your child, but also with the understanding that if they fail, it is okay and you still love them, right? This also brings up a concept of goodness of fit, right? Everyone starts with a temperament, right? If anyone starts from that foundation, how they develop is based on their environment largely. If that environment matches what their natural temperament is supposed to be, they'll develop pretty well. If, let me get this out of the way. Okay, if they don't match up very well, it can be not as good. For example, if a child is naturally sort of rambunctious and adventurous, right? And their parents take that child on sort of like hiking trips or to the park a lot, that would really help them sort of discover that natural curiosity. Whereas, so that would be a very good fit. But if their parents were not that kind of person and was very anxious and wanted to stay in the house and wanted to stay safe and didn't let them explore, that would be a less good fit, and it might constrain their development, and it might sort of change their overall personality. Whereas that first child might be, explorers don't exist anymore, but an explorer or someone who likes to travel a lot. That second child, even though they had the same temperament, might be a bit more reserved or a little more anxious about things. There it is. This is just a refresher. Again, temperament, biologically determined, and it's early emerging, and it sort of determines sort of the groundwork for how we'll interact with the world. Oh, how do I get rid of? Okay. All right. So now that we've talked about what makes a personality, what makes a personality a disorder? Toxicity. Good instincts. And very slang, yes. Toxicity. Instability. Gets in the way of normal function. That'll be a big one. Impaired functioning, causing distress, also a big one. Maladaptive qualities, certainly. Dysfunction, instability. All right. Good answers, good answers. I'm gonna also go ahead and cut this one short because I don't want to run out of time. But yeah, you guys are on point. Mostly, like, you have really good instincts about this right away. And the official, so this is from the DSM-5 that Dr. Bronner showed you earlier. A personality disorder is an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture, is pervasive and inflexible, has an onset in adolescence or early adulthood, is stable over time, and leads to distress or impairment. Now, let's see if I draw again. All right, so big things to note. Culturally informed care is really important in personality disorders. So, if you don't sort of have a great understanding of what kind of culture or background that person comes from, you might mistake normal behavior for something that is a personality disorder. So it's very important to have sort of that cultural awareness. Pervasive and inflexible, I can talk about a little bit later as it relates to treatment, in that this is the core of who you are. It is very hard to change this later in life. It is stable over time. Do you guys? Can I get a check from Bernie or Dr. Bronner? Do you guys see the chat on screen? Because I do.
I don't know where to see
Yeah,
it.
I see the chat. There's no questions right now.
Okay, gotcha. All right, so stable over time. This is an important one. Sometimes you'll see, or you may have experienced, someone that you know, if they get intoxicated, maybe they get too drunk, their personality changes. And so you can't diagnose someone with a personality disorder if they're acutely intoxicated. The same is true if you have an acute mental health crisis. If someone suffers from depression and they just get very, very irritable or withdrawn while depressed, it doesn't mean that they have a personality disorder. It means that they're struggling from depression. So you have to be able to separate these two things. Now, someone can certainly have exacerbated two separate mental health conditions, such as a personality disorder and a mood disorder, but you have to have them separately in order to make a diagnosis. Again, the most important thing is leads to distress or impairment. Some of these personalities that we will talk about, you probably won't encounter as an advocate because they don't interact with the healthcare system. They just don't. They don't see anything wrong, and they're totally okay with it. All right, cleared all my marks. Let's move on. All right, I'm gonna try and go through pretty quickly the types of personality disorders. If you have a question or want me to go back, let me know. I can certainly go back. I've tried to tie in sort of pop culture references that most people would get, but again, it's not going to be a home run on all of them. So we've got 3 clusters of personality disorders, and the way I like to remember it is cluster A is weird, cluster B is wild, and cluster C is worried. So the 3 W's: weird, wild, and worried. On this slide, I have a sort of a diagram representing all of them. The official sort of description of each cluster is written in these top bubbles here. Cluster A, cluster B, and cluster C. Cluster A in particular is characterized by odd or eccentric behaviors, hence the weird designation. Cluster B is characterized by dramatic, emotional, or erratic, hence the wild classification. And cluster C is characterized by anxious or fearful behaviors, hence why I said worried. So, I understand it can be a lot to remember, sort of like categories of things, but if you remember in general, cluster A is weird, cluster B is wild, and cluster C is worried, you can sort of help categorize things if you don't remember. All right, first one we'll talk about cluster A first. So I found these great sort of mnemonics online. If you are someone that learns well with mnemonics, I have them here for you, and I think you should be able to get access to this set of slides after this lecture. But someone who's paranoid, they hold grudges for a long time. They're not very trustful. Very frequently, this causes problems with relationships because they'll accuse someone of infidelity. If you say something even slightly negative about them, it's an attack on their character. They don't like to confide in others because they don't trust anybody, and they read seemingly innocuous things as very threatening. So, like someone delivering the mail, they might perceive that as a very, very sort of spy or sort of incursion into their property. Someone in there's not great ones that I've thought of off the top of my head, but if any of you are Star Wars fans, and the 3rd Star Wars movie, Anakin Skywalker is turning into Darth Vader, and he gets just this wicked case of paranoid personality disorder. He starts thinking that Obi-Wan and his wife Padme are conspiring against him. He only trusts this one person, Emperor Palpatine, and he is mistrustful of the entire Empire and the Jedi Order as a whole, to which the moviegoers had no reason to suspect otherwise. If you haven't seen the Star Wars movies, I'll try and think of another example, but this pictorial should be a very good representation. All right. Schizoid personality disorder is another cluster A personality. It's characterized by a very solitary person, but the key here is that relationships hold no interest to them. There are some other personality disorders which lead to sort of withdrawn behavior, but in other personality disorders, relationships are of interest. In schizoid, they have every desire to be a hermit. They don't really do things for fun. They don't have friends. They're kind of cold and detached. They just don't care really about what others think. Now, this picture graphic here, I disagree with. I don't think that very adequately describes schizoid. They're not particularly fearful or hiding somewhere. So that's why I disagree with this guy hiding behind the chair. Someone who is a decent description of schizoid is Squidward from SpongeBob SquarePants. I mean, as much as SpongeBob or Patrick might annoy him, he has an indifference to personal relationships, at least that we've seen. Everyone in the show that he interacts with, he has no interest in. He does play his clarinet, but otherwise is basically doing nothing. And he's sort of indifferent when Mr. Krabs gives him job reviews, when SpongeBob offers advice, he's totally indifferent. So it's kind of the best example I could think of. Schizotypal. Sorry for the blurriness on this one. The schizotypal personality disorder, basically think of the person who kind of believes in aliens, thinks that people are trying to reach them. They can also be suspicious, but they're also kind of reclusive. They're pretty friendly overall, but they're kind of this like pleasantly sort of eccentric person. A good example, Luna Lovegood from Harry Potter. Very good schizotypal personality. Just sort of friendly, just really kind of strange. Isn't really outgoing for friends, but is sort of friendly to people when they approach. And also has sort of odd and magical thinking. All right, cluster B. Actually, one more thing about cluster A. You probably won't see too many cluster A people if you're doing sort of any kind of advocate work in mental health care. You may see some degree of paranoia, which debatably would be the paranoid personality disorder, but in general, these people don't necessarily seek help because they don't think anything is wrong or they don't trust mental health providers.
There are two questions.
Yes.
One is, what is the utility of the diagnostic criteria for personality disorders?
That's a good question. So if you are able to engage someone who has a personality disorder, you will be able to tailor some sort of psychotherapy to help address that. Now, that also implies that they have some sort of readiness for change or desire for change, and they may not. But the utility of the disorder label is that they are actively hurting themselves or causing some dysfunction, whether that comes from not holding down a job or damaging their relationships with others, or in the case of paranoid personality disorder, maybe even not eating because they are too paranoid, right? So the utility of the diagnosis would allow them to get treatment that is more oriented towards what would help them. And that question does sort of get at, are these organic diseases? And that's a good question. They really are just people's personalities. And what makes them a disorder is not necessarily any underlying sort of microbiology or anything like that. It really is early life experiences that have shaped who they are. And while we don't have much to treat them, there are some things that can help. And if we can get a diagnosis that could help, and otherwise they aren't mentally ill, the personality disorder is what's left.
Yeah. There's also another question that asks, is there a spectrum within each of these personality disorders, or are these characteristics mostly present for diagnosis to be made?
Good question. So with most of these, a lot of those mnemonics Some of them double up, but a lot of the mnemonics list all of the criteria, and most of the time the DSM-5 will say you need a few of them, maybe 3 or 4 out of 7. And so that does leave room for some variability within each presentation. One schizotypal might look different from another, but very classically, one I'll get to later, borderline, they will look different from each other. And you'll still be able to tell, but they do have different features. So that is a good question. There's sort of a spectrum, both in severity and in terms of symptom presentation. Are there any more, Bernie?
No, that is it. Thank you.
Okay. Cool. Good questions, guys. All right. Narcissistic personality disorder. If you've been paying attention to the news for the last 4 years, you may have heard of this one. So basically, this personality disorder is the first of cluster B that I like to talk about because it's easy to wrap your head around. Once I provide the next example, you'll kind of get that picture as well. Basically, it's a person who essentially have a hollow view of themselves, but they express sort of this very inflated sense of self-worth. But because of that emptiness, they require, so much like reassurance. They're envious of others. They manipulate people to get what they want. And they are all about themselves. So if that sounds familiar, I will say your intuition is correct. But this is the example I came up with from pop culture. Gaston from Beauty and the Beast. He is classic narcissist, looking at himself in the mirror. It's actually named, the narcissistic part of it is named after a Greek, I think it's Greek, sort of mythical figure, Narcissus, who, I forget the details, but basically looked in the river Styx and something bad happened because they were obsessed with their appearance. So it gets that name for a good reason. The next of cluster B's is the histrionic personality disorder. These are people who are overly dramatic, who they think that the relationships are closer than they really are. Like, oh, I've only known him a short time, but he is my best friend. Like that kind of person. They can be inappropriate. They're seductive or provocative on purpose to get a reaction out of you because they crave that emotional input. They are vulnerable to suggestion and they crave novelty. So not the best example and not the one I have on the next slide, but a lot of people on reality television are often portrayed as histrionic because it's exciting, very dramatic, like, oh, I just met them, we're family, I just met you like 2 weeks ago, let's go do this, that sounds like fun, we haven't done that before. The example for pop culture I came up with was Harley Quinn from Batman. Again, if you're not familiar with Batman, basically Harley Quinn is the Joker's sidekick and is undyingly devoted to him. You can argue that this is sort of a dependent, but she is very, very sort of exaggerated and can at times place more value on the relationship with the Joker than he does. So not a perfect example, but definitely an example. It looks like there was a chat, maybe a question.
Yeah, there was a question. Do people become more narcissistic due to the use of social media?
Good question. And my answer would be, I don't know, but I can guess. So there's probably been some literature on it, and I don't know if I haven't seen anything on narcissistic personality traits with social media. What I can say is that it does lead to this sort of keeping up with the Jones type of effect. People are only presenting their best lives in social media. And so you get this sort of feeling like, oh man, like, why does my life suck so much? Like, I'm just sitting here at a computer and they're out here like eating this place or traveling there. But this is you're looking at a curated version of someone else's life. So it can lead for a lot of sort of very focused thought on yourself. And certainly if you're a star on social media, it can lead to that because you're sort of trying to curate an experience that others would like. But I haven't seen any literature on it to specifically comment. All right. Borderline personality disorder. This one and the next one that I'm going to talk about are probably the two most important that you will see because these two often end up interacting with the mental health care system the most. Borderline personality disorder is hallmarked by unstable relationships, intense fear of abandonment, impulsivity, suicidal gestures like cutting with razor blades, chronic feelings of emptiness, very unstable affect, which is sort of a mood expression. They can be paranoid. They have explosive anger often. And they do this thing called what we call in psychology splitting. Splitting meaning you're either all good or all bad. So in the inpatient unit, when we have someone who has borderline personality disorder, we'll often say, did you fall on the good side of the split or the bad side of the split? Because very often and very quickly, a borderline person will try and split the staff. You know, this nurse is very good and everything that it does do is right. And this nurse is awful. They're the worst and nothing is good about them. And that's sort of a very, very immature defense mechanism to sort of shield their emotional brain from trying to process that people do have good parts and bad parts about them, and that's okay. And it helps them not have to tolerate that. This is not a good example of borderline, but a way you can conceptualize it is Bruce Banner and the Hulk, right? Bruce Banner, at one time he's totally charming, just a normal guy, and then he gets angry, something upsets him, and he just becomes this monster, right? And that's sort of the way to frame it within your mind. Antisocial. This one is the dangerous one. You may have heard this one as the serial killer personality disorder. And sometimes it does live up to that name, but other times it can look different. It has a correlate in younger folks named conduct disorder. Basically, that's before age of 18. If you get in a lot of trouble and get diagnosed with this, you're more likely to develop antisocial disorder, personality disorder. Basically, they only think of themselves. They don't care about social norms or obligations to others. They can't plan ahead. So they just do what's right for them in the moment, even though it'll badly affect them later. They'll lead to money trouble because they can't plan ahead. They just, hey, I want a TV, let's buy a TV. That was all the food money we had for the month, that kind of thing. And oftentimes this is where you'll see aggressive behaviors, assaultive behaviors. And so this is one you'll definitely want to look out for. I mentioned in my second lecture that safety is #1 priority. Definitely with antisocial personality disorder, that's what you want to be thinking as well, is safety. And if you've never seen the show Dexter, I'd recommend it. It's a pretty interesting show. It's about a serial killer who kills other serial killers. But the reason I bring this example up is because antisocial personality, they can be very superficially charming at first. And this character is the main character, Dexter. He is superficially charming, but again, has no internal superego or conscious to sort of hold him back. And that's what makes it scary. Now, dependent personality disorder, again, just think of someone who basically can't function on their own, right? They desperately seek a relationship to sort of conglomerate onto, and they have difficulty once that relationship is taken away, right? They kind of struggle on their own. They have difficulty initiating those tasks that they need to survive, and in a sense, they sort of crave just they totally are parasitic almost to that person that they have related themselves to. If you've never seen Arrested Development, this is Buster Bluth, the youngest child of the family. Any character that this man plays is a pretty good example of dependent personality. He does a pretty good job at it. He's pretty typecast at this point, but it's a very good example. He is very dependent on his mother, and when he's on his own, he is helpless. Avoidant personality disorder. This on the surface might seem similar to like a schizoid. You are sort of withdrawn. But comes from a different place, right? You're expecting that others think of you in a negative way. You don't get involved, but it's because you're sort of afraid of that criticism. The difference is you are desperately longing for attachment to others, but you are so scared of the embarrassment of social interaction that you can't go forward with it. This will often be a self-fulfilling prophecy because it'll lead to poor performance, not because they're inadequate in any way, but because they're afraid of appearing so and not getting what they need to done. Great example is Elsa from Frozen. Basically, the whole first movie, she spends trying not to show anybody that she has powers and then runs away to the mountains, right? That's classic avoidant personality. And the last personality disorder is obsessive compulsive personality. This is basically someone who maybe in pop culture might be called OCD, obsessive compulsive disorder, but really it's just that they like rigid things, they like organized, they like to be productive, they don't like to spend money, and they're hoarding things. It's not a obsessive compulsive disorder in that they don't actually have obsessions which compel them to do things. They just like to be very neat and orderly. Hare from, or Rabbit, I'm not sure what the character's name is, but I do remember as a child watching Winnie the Pooh and thinking, wow, this rabbit really likes to clean things and really is bothered when people get his house out of order. That would be what I'm sort of talking about. All right, we'll try and, we don't necessarily have time for these cases. I would much rather talk about what else. So I'm going to actually skip them. Feel free to go over them after the lecture. The reason that I do these cases is just to illustrate that there is some ambiguity, right? We can do one, and then I'll skip over the next two. So Mark, a 48-year-old man, prefers to work the third shift as a word processor for a law firm. His coworkers see him as unwaveringly serious and cold. He does not participate in any social functions and rarely speaks to any of them. He gives short answers to questions and is unlikely to participate in water cooler sessions. All right, so what personality disorder was that? All right, we got to vote for schizoid. Avoidant. All right. In the interest of time, I'm going to go ahead and talk about things and then move on. So I deliberately put ones that could be easily confused with each other. And in the end, it's only a paragraph. We can't tell for sure. There's not enough information here. I think avoidant and schizoid are both reasonable. Obsessive compulsive is also reasonable. The way I would rank them in my mind would be schizoid is number 1, obsessive compulsive is number 2, and avoidant as number 3. Schizoid being the primary one because the only thing we have is that he's preferring not to socialize with others and he's very cold and sort of distanced. Yeah, you can see that in obsessive compulsive as well, and we don't really have a history for how he does at work, which would tell us a lot more. And we don't know if he's avoiding and appears anxious, or we don't know anything about his inner workings. We don't know if he desperately wants that connection. So all good thoughts, but I think all three of those are pretty reasonable to say.
There's a question. Someone
Sure.
asked, how can someone distinguish between schizoid personality and natural introvertedness?
Good question. So with a schizoid personality disorder, they will have sort of an unnatural blunting of their what we call an affective expression. What that means is someone who's introverted, you can still tell that they're experiencing emotion, right? Someone who's schizoid really wouldn't show too much. And introverted people, it's still enjoy social interaction to some degree, right? Now, it's not necessarily how introverted people recharge their batteries. They like to stay at home, but they do still like seeing family or a select few friends. So it comes down to that question of, does it impair with their daily functioning? And work is another indicator, right? So if you're still not interacting with people even at work where you need to, that's another indicator.
Yep, those are all the questions.
Okay, cool. All right, I'll talk about treatment briefly, and then we have a breakout room. All right, so we talked about psychotherapy a little bit with the trauma section, and I briefly alluded to it at the beginning of this session. There's not a whole lot of treatment for personality disorders because this is a deeply ingrained part of who you are. That said, if someone seeks help and is ready for change, you can target some of those things. And a core sort of goal of psychotherapy is to make something that you may not be aware of fully in your awareness. So if you weren't aware that you were sort of being standoffish and not really wanting to interact, if a psychiatrist or a psychologist or a therapist brings that to you, you might say, maybe I should change. It doesn't work 100% of the time. I'd be lying if I told you it does, but it's something that you can try. Something that works for cluster B personality disorders specifically is DBT, or dialectical behavioral therapy. I can talk a little bit more about that later. But what I talk about now is incarceration. With antisocial personality disorder, sometimes that's your only option. If they are not in the change mindset, if they don't care that they're hurting others, they sometimes just need to be incarcerated. A brief aside, all mental health conditions are much more highly represented in prison. Specifically schizophrenia and other psychotic disorders, and some personality disorders. Some of the estimates are, they vary pretty widely, but borderline can be up to 30% of incarcerated individuals, and antisocial traits and behaviors are seen in up to 80%. So that's a huge swath of the incarcerated population. And that sort of makes sense from what we were telling you. Explosive, not caring about social norms, sort of ineffective interpersonal communication. Those are all things that would possibly land you in jail. So DBT skills. So Bruni will send you out the homework, and I've given you a select number of these training manual worksheets by Marsha Linehan. This is used across the country by all mental health providers. It's like almost like the DBT Bible, right? It's a really good collection of work. And you might be surprised by some of the stuff that they work on. It's sometimes even just naming emotions, right? And here's all the components listed out. Analyzing behavior. Why did I do that? What emotions led me to do that? Like Dr. Bronner brought up, mindfulness is a big thing. Expressing or listening to what's going on right now and being aware of it. Interpersonal effectiveness, some of those unstable relationships. You need to be able to interact with people if you're going to live a normal life. Emotional regulation, that's that explosiveness that I demonstrated with my Hulk comparison. And distress tolerance. You can't just be exploding about every little thing. And individuals, especially with borderline, are much more apt to sort of dysregulate when something very, very minor happens. So you're working on tolerating that distress. All right. So this is what we're going to do our breakout room on. We're going to do something called transference and countertransference. As you deal with people in the mental health care system, you want to be aware of these skills. Transference is the redirections of emotions onto another figure. Typically, you'll experience it, you say that you're mad, right? A classic example is like, if you're mad, you're blaming someone else for being mad. It's like, oh man, you're so mad. Why are you so mad right now? But it's you if you're experiencing that emotion. But a big thing to be aware of as someone who will be taking some role in someone's life who has a mental illness is countertransference, the experience of transferred emotions from another person. And the best way to conceptualize this is be mindful of what you're feeling as you're listening to something, as you're hearing something, as someone's telling you their story. The emotions that you feel are helpful and will guide your actions. So the classic example that gets brought up in the psychiatry world is someone who is manic and someone who is borderline personality disorder. They might present fairly similarly, talking fast, very up and animated, but the feelings that you'll have in the two situations will be vastly different. If you're manic, you might feel exhausted, but you'll kind of feel happy. It's like, oh, I kind of like that person. If you're interacting with someone who's borderline, you might get the opposite impression. You might just not like them, and you might kind of want to get away. And that's something to be mindful of. So here's our activity. And I'll have to shorten it for time reasons. So I'm going to read this aloud. And what we're going to do is we're going to go into breakout groups. I was going to do this twice. I'm only going to do this once. I'm going to read this, and you're going to go into breakout rooms and discuss what was the overlying emotion that you were feeling that I had based on what you were experiencing. All right. So I don't really know why I'm here in this inpatient unit. I started therapy. I had one appointment with my therapist, and they said to come here because he was worried about my safety, which is totally unnecessary. He totally misunderstood me. Yes, I'm anxious. Yes, I'm having panic attacks. Yes, I sometimes wish I wasn't here, but I'm not going to kill myself. I was looking forward to starting therapy. It's been on my calendar. I even circled it. I know that sounds silly, like it was my birthday or something. But here it isn't what I expected. I've never been in therapy before, and I read a book about starting therapy. What do I do? I wanted to know what you do. Like, you see people in movies talking about really important things. Like, I guess you could talk about my father, but I feel like I have silly things to talk about, like being irritated at my husband a lot. I mean, I love him, but he drives me crazy. That's not a very big thing. Other people have really bad problems, like other folks in this unit. Maybe my problems aren't important enough. I don't mean important, but like severe, like other patients, something like that. My problems are upsetting me, but how much time do we have? Anyway, what was I saying? Speaking of family, they always thought therapy was a waste of time. I never thought so, but I don't know, especially after learning it. What do you think will help? Will therapy help when I leave? All right, so that was a lot. What I want to do now is I want to set up into breakout groups. Let's give 3 minutes to talk about it, and then we'll come back and sort of discuss as a group before wrapping things up. All right, looks like people are coming back. If I could get 1 or 2 people from a different groups to try and speak up, some brave souls to speak up and what their overall impressions were. I know I'm not the best actor.
Can you repeat that? I think there are more people in the room now.
Oh, yeah, okay. Yeah, so maybe not everyone was in. If I can get 1 or 2 people to sort of bravely speak up and say what their primary feeling was when I had read that, what they thought I was experiencing, what the overall emotion was of what I was reading.
I mean, you were speaking kind of quickly. There's a lot of, I don't know, almost like a stream of consciousness kind of feeling to what you were saying. I don't know. I would say that this person maybe is underplaying what's really going on.
Yeah, I think that's what I was going for. Great job. The reason I wrote it sort of in this way, if we had had more time, I would have read it again. There's also ways to read this that it comes off very, very sad and depressive. So that's why it's important not just to look at what the words people are saying and what the underlying emotion was. And I tried to read that very quickly, sort of downplaying things. And that's something that you might see from someone who has a personality disorder, is that they're not really, they're sort of superficially going over things like, I'm good, I'm okay, nothing's wrong. I think that was, yep. All right. There you go. So Bruno's going to send out these articles, and I don't need you to fill them out, but it would be helpful just to read them, sort of familiarize yourself with some DBT skills. But I did want to answer some of these questions that I saw in chat before I wrap things up. Where is chat?
The first one is related to this: given the ambiguity of a lot of symptoms, how much of these are disorders as opposed to neurodeviance?
Good questions. Neurodivergence, everyone is different, and that's sort of getting at the sort of the heart of personality versus personality disorder. And I specifically did not include DSM criteria because there are very long and lengthy diagnostic criteria for these. And so we're not doing it based off those images that I showed you. But the diagnostic criteria in effect, like, wouldn't do anything if the person's not interested in help and the person wasn't truly experiencing harm from their personality disorder. So some of these things may go unnoticed in the population if they're managing okay. And in that case, is it really a disorder? But that's a good question.
Yeah. And then the second question was, do you see countertransference often in someone who grows up with a relative who has a personality disorder?
That's a good question. So countertransference is someone that is observer dependent. And everyone can experience countertransference if you sort of listen correctly. It's really just something that we use every day. I'm just putting a name to it. It's trying to understand the feelings of somebody else. You may experience it more heavily in someone who is interacting with you who has a personality disorder. But in someone who is normal coping, they will process a lot of their emotion internally. You'll still be able to see it, like in a smile or in a frown, but they'll process it a lot of it internally. And so they won't force a lot of it on you. And someone with a personality disorder, a lot of times, especially with cluster B personality disorders, they are looking externally for validation. So you'll see it a lot. You'll be aware of your countertransference a lot more frequently because they are looking for that external validation and they are not sure that their feelings are correct. So they're looking for that from you. And sometimes that can make you uncomfortable. And you'll see that sometimes with cluster B personality disorders.
Thank you. Those look like all the questions.
Yeah. Anyone else have questions?
Sounds like a no.
All right. Thanks everybody for coming.
Thanks,
Thank
everyone.
you.
Thank you so much.